So our next speaker, Natalie, mentioned genomics and the importance of getting her tumour sequenced and genomic testing and how that's played a big part in her cancer journey. And we're going to continue that theme for the next little part of today's event. Our next speaker is Professor Matt Brown. He's the Chief Scientific Officer of Genomics England. He's a clinician-scientist who originally trained in medicine and rheumatology in Sydney, then did a Doctorate of Medicine at the University of Oxford. He's been the Chief Scientific Officer of Genomics England for the past 6 years, where it's been through a really significant period of change and expansion in genomic testing and capacity and capability in England, which you'll hear about. And his work focuses on the genetics of human diseases with a focus on common and rare bone and joint diseases, cancer genomics and personalised medicine. So we're absolutely delighted to welcome Professor Brown back to Australia to share his insights. Please welcome Professor Matt Brown.
All right. Well, good morning all, and thank you very much for having me here. Actually, I have to thank Professor Dame Sue Hill for my being invited here. Sue is the Chief Scientist of the NHS and the head of the NHS Genomics Unit, and who was originally invited to speak here but was unable to attend, and therefore she suggested me attend in her space. And I guess in the next 25 minutes or so you're going to work out whether that was good advice or not. I'm going to kick off by just telling you a little bit about the history of how the National Health Service of England's Genomic Medical Service actually evolved, and take you back 12 years to the 2010 to 2013 period, where the NHS's genomic services were very similar to the situation in Australia. That is, they were extremely fragmented. They were largely provided on a laboratory level by a mishmash of university research laboratories and small regional pathology hubs in different hospitals. And there wasn't a centralised system for determining what would be funded and provided. And there was a lot of inequality and variation in service as a consequence of that. And in 2013, the Prime Minister of the UK announced that there would be a major shift to try and develop a national program for genomics for rare disease and cancer, and established Genomics England to actually run a pilot study together with the NHS called the 100,000 Genome Study. At that point, I was in Australia, and there were probably only a couple of thousand genomes that had been sequenced worldwide since the first genome had been sequenced about 10 years before that. And so we all thought 100,000 genomes sounded like a good number, but it was probably just publicity, and they weren't actually going to get there. But of course, over the next 6 years, they did, and 100,000 patients with either rare diseases or cancer were recruited from NHS clinical services, so not a pure research program, and had whole genome sequencing performed, and then basically a whole lot of implementation work was done around that, which meant that then from there we knew actually how we should be delivering sequencing services for rare disease diagnostics and for cancer personalised medicine. So I think the key thing out of that was that firstly it was real world. So that meant that it had direct relevance to how you would actually deliver a service in an actual healthcare system. And the second thing was that the government did actually follow up where they had funded a research program and then transitioned that into actual clinical care. And that's something I see has occurred repeatedly in Australia, where funding for various research programs, in particular through the MRFF, has not actually ultimately ended up in translation into clinical care. And that's a real deficiency in this country. Okay, so Genomics England should just briefly explain what we are, because I think it's pretty integral to the system that there's both a healthcare side of how this gets performed, that is predominantly the NHS, and a research arm and development arm, which is predominantly Genomics England. And so Genomics England is a company. It's actually wholly owned by the Department of Health, and it is not the NHS. But we work together very closely with the NHS in both providing whole genome sequencing services and in doing research for the development of those services, and using the data that comes back from NHS services to improve rare disease diagnostics and cancer personalised medicine. So I think I see David Bentley in the front row. But if I could just say that how this actually works in practice is that the whole genome sequencing test ordering is done through the NHS. Then samples are sent to an Illumina centralised laboratory in Cambridge where they're whole genome sequenced. And then from that, all of the the analysis gets done by Genomics England pipelines and returned to the NHS into the NHS's 7 genomic laboratory hubs, which are spread around England regionally. And the actual reporting that gets done is done in those genomic laboratory hubs. In the next 12 months, the sequencing is going to shift and decentralise so that the actual sequencing will be done by the genomic laboratory hubs and not in the centralised single sequencing facility. And I think that provides a model about how a system could work in Australia where you have federal and state healthcare systems and a need to incorporate both in how you might actually provide genomic services in future. So how is this actually rolled out? So at the end of the day, about 90% of cancer sequencing that gets done is actually panels or whole exomes. Increasingly, this is shifting towards whole exomes, and the expectation is that over the next 10 years or so, as sequencing costs diminish and our ability to actually analyse and report these improves, that it will shift more and more towards whole genome sequencing. Certainly, I think panel sequencing over the next 5 years for most cancers is actually going to become a minority. So we run at Genomics England around about 5,000 whole genome equivalents per month. Most of that is rare diseases, so 3,000 to 4,000 whole genome sequences for rare disease a month, and about 1,000 patients have whole genome sequencing per month, which is a 2 times tumour and a 1 times tumour normal genome, so 3 genomes per cancer patient. And the most common indications actually include a lot of rare cancers, so acute leukemias, sarcomas and so on. Paediatric cancers are obviously rare cancer groups, but they're amongst the majority that we test. But in addition, we obviously provide for CNS tumours, high-grade ovarian cancers and things like that. And a key part of this is that the genomic services in clinical space are linked up to research such that all patients who have whole genome sequencing are asked to consent for their information to be made available to researchers internationally and to be linked up with their ongoing health data from their NHS records in a database called the National Genomics Research Library that Genomics England runs. That library currently has 200,000 whole genome sequences in it, and by 2030 will have grown to 500,000 whole genome equivalents, which are available free of charges for researchers around the world to use for research purposes. All right, so in transitioning from the research setting to the clinical space, the NHS has various principles, and these were applied to how that was actually rolled out. So the principles include that the NHS provides a comprehensive service that's available to all. So equity is built in at the very top. Access to the services is based on clinical needs and not on an individual's ability to pay. So whilst you can go and pay for private healthcare, actually there's comprehensive healthcare provided on the NHS. I'm not saying that that healthcare is perfect, it clearly isn't, and NHS cancer services lag those from many other countries. On the other hand, in the area of equity, it's certainly absolutely leading. And then another principle is that it works across organisational boundaries. So there are 91 NHS trusts in England alone that are involved in running hospitals, and a total of 215 trusts overall, which are all individual contracting units. But the government took the decision at the end of the 100,000 genomes program that they were not going to base genomics around those trusts, but instead they were going to base it on what actually made sense for the service. And it would be lovely if we could see that happen in Australia, where clearly the fragmentation between state and federal is impeding the rollout of cancer sequencing across the country. All right, another major thing that was done by the government at the end of the the 100,000 genomes project was the introduction of what's called the National Test Directory System. So in one review process, the government got together experts across rare diseases and cancers to look across all different disease indications and all testing types, and determined for what cancers, in regard to cancers, what test would actually be applied and what genes would actually be reported back on. So note this was by cancer, not by drug indication. And so if you have a particular cancer, irrespective of what drug people are thinking of treating you with, you can have a particular test done. And then there was an obligation on all genomic laboratory hubs to provide that test for all patients who have that tested ordered for them for that cancer type. And so it provides equity of access across the country with centralised funding for that, and with an annual review process, which is a really simple process with a form that even lay people can fill in, an institutionalised regular review of what's actually available on the test system. So it's a simple, centralised public system that anybody can go on the URL that I've put up there and look at what tests are available for their particular cancer type. And it has to be provided and is provided by the genomic laboratory hubs around the country. So these are the tests that are available. I won't go through them all, but basically the tests that are commissioned for whole genome sequencing add up to around about 10% of all cancers that are seen in the NHS and include particular major cancer types that many people here today will have had lived experience with. All right, I was asked to talk about what the future is for the NHS, and in that I'm very lucky in that between the invitation and me actually giving this talk, two major policy statements came out in June and July. One was the NHS 10-year plan, and the other one was the Life Sciences Sector Plan. These 10-year plans are actually stuck to very closely by the UK government, although in this case it's NHS and most of the plans relate to NHS England. So the three key goals that the NHS 10-year plan talks about are transferring healthcare from hospital to the community, from analogue to digital, and from sickness to prevention, so preventative care. And there is an extremely heavy emphasis on genomics through this report. Genomics' report is mentioned nearly 100 times through the 10-year report, and you can see that genomics is considered to be a major part of how NHS is going to provide services by 2035. In fact, it's an expectation of the NHS that half or more of healthcare events that occur in the NHS, so appointments and so on, will involve genomics by 2035. And so that is going to require an absolutely massive upscaling of the amount of genomics that's performed within the NHS. Even though the NHS is extremely well positioned already for genomics, it's still going to be quite a challenge. So the initiatives include that they're going to introduce a new genomics population health service. So that's going to look at, for example, the introduction of polygenic risk scores and cancer genetic risk or screening and preemptive pharmacogenomics across the UK population. They're going to ensure that across the UK, not just across England, that there'll be universal access for cancer patients to comprehensive genomic analysis, whatever that means, but the expectation is that that means at least a large-scale panel for testing for cancer personalised medicine. They're going to integrate pharmacogenomics into routine healthcare, and with that in mind, they have just announced funding for Genomics England to run a pilot of studying 150,000 adults, which are described as later life adults, and I'm sorry for folks who are of my age and beyond, but that means 50 plus, who are going to have whole genome sequencing, and that data is going to be then fed into their healthcare records and intersected with electronic prescribing tools so that there is proper preemptive pharmacogenomics, and ultimately that's going to be rolled out across the population. There's already work going on towards a unified genomic record. I was showing some people earlier the NHS app, which is fabulous, but the unified genomic record is going to be linked to that and mean that if you move around the UK, your genomic record will follow you with you and will have access through the app to be able to identify whether you carry particular variants, what your polygenic risk scores are, and what your pharmacogenomic variation and so on is. And lastly, they're going to expand clinical trials considerably. Talking in front of an audience that has David Thomas and Omiko in the audience, I feel that this is a bit behind the times, but at least we're trying to catch up with you there. And that involves speeding up setup time, doing recruitment through the NHS app, so it'll be direct-to-patient recruitment, and having a single point for contracting instead of the current situation where you actually have to, if you want to run a clinical trial, actually have a separate contract with each of those NHS trusts that you might work with, which can add up to literally hundreds of contracts that you have to sign. So the Life Sciences Sector Plan was related to that. It comes from a different part of the UK government, but it also has major commitments to driving genomics. And I put this up here not as in any way to show off or to try and compete with the important initiatives like Genomics Australia that have recently been announced, but just to show you the scale of investment that's going on in the UK and to indicate to you what I think the scale of investment is going to be required in Australia if you are to truly deliver on the promise of genomics for healthcare over the next 10 to 15 years. At the moment, to be frank, I don't think this country's aspirations and funding are anywhere near where it's required to be to actually deliver on the possibilities. So the funding that's actually been announced in this year's spending review, so this is committed funding, is over £350 million to Our Future Health, which is a program which is recruiting and is well on the way to recruiting 5 million people across Britain for comprehensive genomic profiling, which at the moment is a SNP microarray, but likely will transition to a whole genome sequence for polygenic risk score calculations and other healthcare service needs. 20 million to UK Biobank for comprehensive proteomics of their 500,000 patients, and £650 million to the organisation I'm CSO of, Genomics England, for our adult population genomics program, various cancer initiatives and cancer clinical trial programs, in particular linking up all NHS clinical genomics services such that if you have a cancer genomic test done in the NHS, it will automatically be interrogated to see if you can fit into a cancer clinical trial. And lastly, expansion of the National Genomics Research Library to over 500,000 genomes by 2030. That will include the sequencing of babies. So we're currently running a pilot study of sequencing 100,000 newborns to replace heel prick testing at birth, or to be in addition to that, so that treatable genetic diseases are picked up at birth, including cancer risks. And that's expected that ultimately will be rolled out across the UK population over the next 10 to 15 years. And now, of course, translating that into actual clinical care is far harder than actually doing the discovery science. And NHS is going to take a hell of a lot of work to actually get that built into clinical care pipelines. But it has got many things which are examples of basically how we can go about it and what are the successful things which I think are models that you should look for here in trying to actually drive genomics forward here. So a key thing has been that there's been strong national, public and high-level political support for genomics initiatives. That means that you repeatedly see announcements from ministers of health and from prime ministers who go out there and make public statements where there is great public pride about genomics in the NHS. So it has got a huge level of support there. That's bipartisan. There is a single national genomics service within NHS England. Instead of having fragmented services, that means we have efficiency of how we provide sequencing, and perhaps even more important than that, how we provide analysis pipelines, because the people who develop those analysis pipelines and run and maintain them are actually a very small subset of people who have got rare skills. And if you have a situation, as is the case in many areas of Australia at the moment, where you have each small company or small pathology lab trying to set up their own pipeline, that is incredibly wasteful. There has been sustained long-term funding for translational genomics programs, so there has never been a situation where you get to the last month or two before your program in paediatrics cancers or anything else happens and you don't know whether you're actually going to get funded going forward. That just doesn't happen. You do know that you are going to be stably funded going forward, and that's critical for these really difficult to develop programs to have that sort of stability. The government has funded, as I mentioned in the previous slide, large-scale national organisations to drive large-scale genomics research and service development, and linked up the research and service development. There's been major investment over 20 years in national health data collection and accessibility, with now the building of large-scale databases and secure data environments to house all of NHS clinical data, including GP-level data, so that researchers can use it and healthcare epidemiologists and service delivery people can use it to improve healthcare. The National Genomics and Research Library, linking up NHS clinical service in genomics to a research library at a national scale, has built what is a globally leading program, which is currently the largest cancer genomics database worldwide that's publicly available. And there is a very streamlined process for test approval and adoption, which I mentioned in the National Test Directory. These are just a few examples of ministers standing up and giving high-profile statements about the future of genomics and how this is seen as a major political advantage for people to be going out there and saying things. And there's great civic pride in the UK for the genomics program. Related to that has been the fact that there's been extremely strong public engagement with the NHS programs, and in particular in the use of NHS data for research, so that we don't have situations where we have a lot of pushback about access for data from academics around the world and even from pharma companies around the world to be able to use this to better healthcare outcomes. This example I put up there is the Genomics England Participant Panel, which has been in existence for over 10 years that Genomics England's been around, and where all of our key research decisions go through before we actually roll them out, and where we have participants involved in determining access for researchers to our National Genomics Research Library and all of our different programs, essentially. So there are plenty of things that we could do better. I'll go through a list of these, and I think that many of these will apply to Australia as well. So we are not great at mainstreaming genomics. So in particular for heritable disease genomics, this means that it's still largely the remit of the clinical genomics community, and that is absolutely not scalable to doing a national scale program where a large section of the population actually ends up being sequenced. So we need to transition from specialist care for genomics to something where it's actually part of everyday healthcare services. So there's also a disconnect between our ability to actually order tests, run sequencing, and then provide reports. So at the moment, about 90% of the time it takes between when somebody orders a test and the report going back to a clinician is actually the time taken at a clinical scientist level in a genomics laboratory hub in actually writing the report. So for rare diseases, for example, that delay is around 9 months, whereas the sequencing time is about 15 days. So ensuring equity of uptake is still not 100%. So there are different areas in the UK where, although clinicians can order the tests and it's funded, they don't actually do so. So uptake of test ordering is very variable, and it would be no surprise to you that it actually tends to relate to association with socioeconomic status and with various regional aspects, so particularly whether you are being taken care of at a primary teaching hospital as opposed to a secondary district general hospital. And so we need to overcome that. Our consenting and test ordering processes are still quite manual. And again, this is an area where we actually have a lot to learn from Australia, where particularly the Omico model, I think, is fabulous. And I've had David Thomas on the phone to the UK trying to convince people to take up that model, which I think is excellent. Patient recontact for research is still a difficult thing for us to do, but is a major goal for the future. That is that we can use people's clinical data to approach them about clinical trials more easily. General practice data linkage we've still not managed. I know it's also not managed in Australia, but given that general practice in the UK is all publicly funded, it's a bit of a surprise that we still can't access general practice data. That's expected to change over the next couple of years. I'll talk briefly about ancestry minorities, and I think that's also got lessons here for Australia. And lastly, We do have a problem where our major genomics databases, in particular our Future Health UK Biobank and Genomics England's National Genomics Research Libraries, they're all secure data environments, meaning that we can't allow researchers to work from one to another seamlessly. And we need to work out ways that we can actually do that to make the most of them. All right, so Genomics England has a major development program for technology and for analysis pipelines for the future. I've only got a few minutes left, so I'm not going to go through these in huge detail, but it goes through, for example, the new sequencing approaches where since 2019 there have been a heck of a lot of developments across long-read sequencing, transcriptomics, spatial transcriptomics, liquid biopsy and so on. And we have a centralised system for being able to actually assess the utility of these and to develop them up for clinical practice in routine healthcare. Here it's really fragmented and I don't see any systematic way about how that actually occurs. There's also programs across digital pathology, building digital histopathology into the genomics reporting, multiomics, the diversity which I'll talk about, and improving analytics, and in particular the revolution that's occurring in artificial intelligence in reporting, in analysing and reporting genomes is something that Genomics England and the NHS are investing a lot of time and energy. All right, so now just to finish up, to talk a little bit about ancestry. So many people think of the UK as being, all white Europeans and that it's not a very diverse population, but that is actually couldn't be further from the truth. And at the moment, around about 20% of the UK come from non-European ancestry, particularly of African ancestry and South Asian ancestry, but it's global. And in particular, I live in South London. Actually, white Europeans are the minority in South London. So I'm not going to get into the politics of all that, but given that we have an NHS system which is actually obliged and as one of its founding principles is that you have to have equity, then actually providing for this diversity of the population, which is increasing, is a critical part of our services. So this is a study that we did looking at the 100,000 Genomes Project dataset, which is actually representative of the ancestry of the UK. And looking at the ability of cancer genomic profiling in those 18,000 or so patients that we did from cancer patients amongst that, and according to their ancestry. And what it showed was, and I won't walk right through the numbers in the table, that if you're of non-European ancestry, you are 20% less likely to get a cancer genomics-informed outcome from your sequencing that would actually make a difference to your treatment than if you're of European ancestry. So 20% less likely to be given a molecularly targeted treatment because of, as an outcome of your cancer screening. And the reason for that was a combination of things, but predominantly that actually the amount of research that's been done in non-European ancestry populations on cancers about what their mutational profiles are, or even particularly in the cancer types that they specifically tend to have, is much less than is the case in white European ancestries. And although we don't have outcome data to show that the outcomes are worse, I think it's pretty intuitive that actually if you're getting worse profiling and less informative recommendations about treatments, that your cancer outcomes are likely to be worse. And at the beginning of this, Selena, during her Welcome to Country, mentioned that cancer was a particular issue for Indigenous Australians. Of course, Indigenous Australians have much higher cancer risk, in particular of lung cancer, and much worse outcomes. This is also the case for Black British people and for South Asian British people. It's a problem here, it's a problem in the UK, and we need to be doing much better at doing research and providing services for these people. All right, so just to finish up, I think in the UK at least now, genomics-informed cancer personalised medicine is now standard of care. It's not acceptable anymore to have a major cancer and not have cancer genomic sequencing, at least in England, and it will shortly be across the UK. I personally think that the expansion of personalised immuno-oncology, so we heard about Keytruda and things like that, but personalised mRNA vaccines, I think, are going to be a massive thing over the next 10 years, and that requires large-scale infrastructure for genomic profiling that Australia simply doesn't have, and that the UK is going to seriously struggle with and is going to take a lot of development. Ensuring equity is critical. Cancer is more common and has worse outcomes in traditionally underrepresented groups around the world. And lastly, that concerted, well-funded, stable national efforts are required to deliver what's needed. Thank you.